Okay, hello, ladies and gentlemen. Welcome to level 2 of the Adult Attachment Program's online course. Hopefully you've taken level 1, and so that's the assumption here, is that you have a baseline understanding of adult attachment theory and the varieties of attachment experiences, how they occur, are maintained, the difference between attachment theory in childhood versus adult attachment, stuff around the AAI. That's all going to be things I'm going to assume that you know already. So if you don't, do yourself a favor and just do level 1, so that we can all start on the same page. So without further ado, I've gotten a lot of inquiries about this, starting this level 2, and it's been in the making. Happy to be sharing it now. We are in the middle of doing a group right now around level 1, where there's 12 members, and we're meeting every other Sunday for 2 hours, going over lessons, and it's actually going quite well. So we're going to continue that. But nonetheless, this is an opportunity for you to work at your own pace here and to learn the material. So we will be talking specifically about the 3 pillars model of the 3 pillars model of healing attachment disturbances in adults. And today we're going to focus primarily on the first pillar, restructuring the internal working model using ideal parent figures, or IPF. Now I have in parentheses third here because David Elliott, who you see the co-author there of the book, is on a mission to make the third pillar, collaboration, to make that the first pillar, and to make the IPF the third pillar. And that's his position, and I actually agree. I think it begins with the collaborative orientation, and before you have that collaboration, that rapport, it's difficult to have the full trust of the patient to do the internal restructuring. But nonetheless, I'm going to teach it as the first pillar because that's what it is right now. But if you see it as the third pillar coming up soon, this year, next year, don't be surprised. So just at a glance, the goal of the first pillar, restructuring the internal working model, the old internal working model that's led to the presenting problems. Another word that one might use for this is schemas. We develop a set of schemas about ourselves, our needs, whether we are lovable or not, whether our needs are valuable or not, and whether we can get them met in this life, and how to get them met. All of those things we're learning and forming that internal model, and using the IPFs, using the ideal parent figures that are guided by these 5 qualities that we know allow for secure attachment. The client and the therapist co-create this secure imagery, first on a general level, so the patient's mind can begin to process and integrate what these new qualities feel like. Oftentimes, patients will have never had the experience of being delighted in or encouraged. So, what are these 5 qualities? And I talked about them a little bit in level 1 because they're just so important. And so, to remind you, these are the 5 qualities that are going to be guiding the ideal parent figure's behavior at all times. They'll mean something different to every patient. Everyone will need one or the other to a greater extent because of their experience. In other words, if a patient had a totally unsafe upbringing, then safety is going to be majorly emphasized. I guess that's kind of obvious, but so the first one is safety and protection. The second one is attunement. So feeling seen and known. These ideal parents are not only present, but they know what you're feeling. If you're sad, they know. If you're angry, they know. Emotional soothing. So not only do they know what the child's feeling, but they know instantly what to do. If you're angry, they know what to do. If you're sad, they know what to do. The fourth one is expressed delight. And this one was a big one on my own personal journey of just feeling valued. And this happens by the ideal parent figures really not so subtly expressing delight in the child. You light them up. You are when you walk in the room, their faces just light up, and they're not subtle about it. They are reminding you in a way that feels good that you are the center for them. And then finally, encouraging the best self. So they have no agenda for the client, for the child. They just want to support the best and most unique self-development. So if you've got good enough at these 5 qualities, that's great. But I think you'll notice if you reflect on your clients and patients that at least one or more is probably missing. So another source of IPF qualities is what we call positive opposites. So if you do have the patient's AAI, you can identify what problematic areas are present for each patient. So you'll be able to tell if neglecting is really high, then you're going to have ideal parents that are extra present. If there's no AAI, then just use your clinical judgment based on your intake and any assessments you may do. So there's the experience of close relationship scale, there's the attachment quiz. And when you find out, if you find out, for example, that the patient's father was cold and neglectful, you know the ideal father is going to be the positive opposite. It's going to easily give physical affection in a natural and a secure way, in a way that feels good to the patient. So that's what we mean by positive opposites. And this is just an example of an AAI score sheet. It's scored 1 out of 9, and you can tell 7 is quite high. So we have a highly rejecting mother here. So obviously we would be imagining an ideal mother that was totally accepting of all the parts of the child, even the unwanted and unseen parts from their own childhood. And the third source is just if you know the attachment style. This is super general, but if there's a dismissing attachment, it's because of chronic rejection. And so the ideal parents are going to be fully welcoming. And if they're preoccupied, you can assume that the parents were inconsistent, so the focus is going to be on the consistency and reliability, predictability. So this process of co-creating secure imagery, meaning the patient and the therapist together collaborating to create this imagery, allows the patient to experience caregivers in ways that we as therapists cannot be expected to provide. So, for example, we allow the patient to settle in and imagine that they're a child, and then they can have their ideal parents come in and soothe them and comfort them and cuddle them as much as they would like. And this is obviously not something that we can do as therapists. What we can do is mark the affect, saying something like, yes, really feel that tenderness now as that child, really take that in. Notice that all of that tenderness and good intention is all about you. Something like that. So just some quick examples of how you might begin clients or patients on their journey to understanding these qualities. You might say something about safety and protection, like, imagine that that girl had a completely ideal father figure, and bring him into the scene. Keep your attention in the body of that child, I would say, and get curious about this figure and how they move, their tone of voice, completely non-threatening. They would never harm a hair on your body. Imagine the details of the way that he's being with you that's so very safe and protected, and keep imagining and changing that until it feels just right in your imagination, until you can begin to see and notice his figure there. And then especially notice the effect that that has on your state of mind as that child. Really take in what that's like. And then, of course, you would or could check in with the patient. So what are you imagining? What's going on? And, oh, well, my ideal mother is holding me and it feels really, really safe. And then you might mark that by saying, yes, really make a deep impression of that feeling. Really take that in, that she's holding you and that there's nowhere else she would rather be. And so attunement is about the ideal parents wondering about what the child is feeling and actively trying to label it in a reasonable, accurate way. So they're constantly attuned to your state of mind. And I would say sometimes I've had the experience of clients who have not wanted this degree of attunement, who wanted not to be the center of the attention. And if that's the case, then you just attune to that, as we are the ultimate, models of these 5 qualities. Attune to that and know that, this patient is not wanting that at this time. So anyway, imagine that in a detailed way and notice the effect it has on your state of mind to feel deeply seen and known. That's the attunement. Deeply seen and known. Experience what that's like to feel so deeply seen and known in their mind and their eyes. And then emotional soothing, you might encourage them to imagine that something's happened, something small, and that the ideal parents come into the scene, into the memory, and that they can soothe the child in the way that it really needed, whether it's verbal or physical. You can explore that with the patient, what kind of soothing they need, whether it's a gentle touch or a word or a kiss on the head or a wink of the eye. And express delight. You're imagining again being with these ideal parents and them being openly expressive about their joy and delight of everything that you do. So everything that you do is of interest to them, but more than that, it's a great source of joy for them. And they light up when you come into the room. But most important, these parents are not delighted in so much what you do, but they're delighted in your being. They're delighted in who you are. Really take that in. And finally, encouraging the best self and noting that these ideal parents have no agenda for the child other than to facilitate and cultivate the child's best interest, the child's most unique, strong, and independent sense of self. Every step of the way, as they're getting older, imagine having these parents at every developmental milestone to really bring out that most independent, most unique self. So the arc of the treatments, you'll notice signs of progress to include a reduction in this insecure patterns. We talk about activation a lot in IPF, another word for triggers or any dissociative state. You'll notice a frequent decrease in the frequency and the intensity of those. And they'll have a more coherent sense of their life, their narrative, which we know does a lot for anxiety and increasing emotion regulation. So the restructuring of the internal model can be assumed once these changes begin to become more consistent and more accessible to the client, even in times of distress. And I would say, especially in times of distress, the body learns it doesn't need to dissociate. So some of the basic assumptions: infant attachment behavior begins in the first weeks, but the internal working model of attachment develops between 12 and 20 months, and it usually peaks around 18 months. So in IPF, the attachment representation, the mental object of attachment, is the main target of the intervention. So from this perspective, we believe that using the therapist as a secure base alone as the primary agent of change is inefficient and problematic, because the ideal parent figures can do and be with the client in ways that we just simply cannot. And so we know that attachment-based IPF imagery will more effectively and efficiently develop a new positive internal working model. And that's what patients are coming for in therapy. So mental imagery is the internal representation, and IPF involves actual new representations to replace the old. And also we assume that fostering a calm and centered, relaxed focus facilitates the change process. So hence we often settle the patient in the beginning with 5 minutes of just being in the body and breathing. The imagination is more flexible than memory. So there's a lot more that we can do. They can shape and reshape the imagery to get the best felt sense. And we can better access and meet patients' deepest needs through these IPFs. So some research on the positive effects of secure attachment priming, and that's a fancy way of saying they showed these subjects images of secure attachment behavior before putting them through the experiment. So Selcook et al. Found that activation of a mental representation of an attachment figure following recall of an upsetting memory enhanced recovery. It eliminated effects of memory recall and negative thinking in a subsequent stream of consciousness task. Let me break that down and see if I can make that make more sense. So by activating a mental image of a secure attachment figure after recalling a difficult autobiographical memory allowed for faster recovery from the difficulty of being with the memory. It eliminated negative effects of memory recall. And it also eliminated negative thinking in a stream of consciousness task, which they were given after the exercise. So patients who were shown the secure imagery didn't have negative thinking in a subsequent stream of consciousness task, meaning they just tell you to talk and not think about it, just spew out whatever's on the top of your mind. So activation of attachment representations can influence memory consolidation and reduce unpleasant recollections and intrusions. So that enhanced recovery, being able to recover the memory in a more holistic way. And then Bryant and Ford in 2016, attachment security priming improved positive affect and reduced negative affect relative to the control group. And he stated that security priming activates a sense of attachment security by making mental representations, one's memory, more accessible and salient. So the priming activates these senses of attachment so that the memory of attachment behavior can be more accessible. Norman in 2015 found that individuals exposed to threatening faces exhibited amygdala activation. This is what one would expect, with the amygdala being the fear center in fight or flight. However, subjects experiencing the secure attachment imagery priming before viewing the pictures did not have amygdala activation. I want to just repeat that point because that is huge. Subjects experiencing secure attachment imagery priming before viewing threatening faces did not have amygdala activation. They did not fear. They did not have fight or flight like the control group who did not get the secure priming. So subjects experiencing secure attachment imagery after seeing the threatening faces had reduced levels of fearful intrusion, even on a physiological level, over the next 2 days. And what they mean is, over the next 2 days, they followed the subjects and they had less elevated heart rate, less sweat, less cortisol over the next 2 days. And finally, we have a study that measured heart rate variability and found that secure attachment priming was associated with maintaining a heart rate in comparison to the control group who had major fluctuations in the heart rate. So the attachment priming actually increases or maintains heart rate variability and its physical and emotional benefits via increasing the ventral vagal parasympathetic activity. What does that mean? What that means is subjects who had the secure attachment imagery had regular heart rhythms during the study. Patients who didn't have the secure imagery had abnormal heart rhythms because of difficulty maintaining physical and emotional comfort. And so they noted also that this happens because of an increased ventral vagal parasympathetic activity. That's just fancy brain speak for your vagal parasympathetic nerve becoming activated, leading to less activation. So comparing IPF to traditional therapy. So the therapist's ability to be best and consistent secure base for any patient is limited by the therapeutic boundaries, of course, and his or her own attachment patterns. Therapist behavior is also limited. It's less flexible. When the therapist does not behave as a secure base, which can happen, there's a greater likelihood of transference reenactments and difficulty recovering from ruptures. And to just interpret distortions of the internal working model, which would be sort of like the CBT way or possibly another psychodynamic theory, it doesn't lead to positive remapping. So we're going to transition a little bit to talking about IPF and trauma. So specifically on the AAI, we assess resolution of trauma through the speech. We know there are certain maxims of speech: quality, be truthful; quantity, be succinct; manner, be clear and orderly; and relevance, be relevant. Everybody has a baseline level of coherence. We place no judgment on that. What you'll notice with patients with unresolved trauma or loss is the coherence will be going along quite normally, and then the traumatic event or the loss will be brought up and the coherence will drop significantly. And then when we come out of the traumatic event or the loss and we're talking about something else, the coherence returns to the normal baseline. And what we think is happening there is that there's unresolved material kind of floating around up there that's preventing that easy, natural flow of communication that you've evidenced you've been able to do in other parts of the interview. So a lot of the ways that we determine is through affect dysregulation, lapses in self-monitoring, dissociated parts, feeling an impaired sense of self and agency, impaired exploration, and most salient is that the source of attachment is also the source of fear, creating this push-pull, approach-withdraw dynamic. And so we know that one of the factors leading to PTSD is called peritraumatic dissociation. And what this is these are little dissociative reactions that occur during or immediately following a traumatic event, sometimes not even noticeable to the consciousness. There are perceptual distortions of time, of place, or person, disruptions in sensations or perceptions, and memories are usually memories that are usually well integrated. So some of the dissociative states are depersonalization, which means not feeling like you are yourself. Derealization, which is not feeling like the world is real. Emotional numbing, which is just that. And disembodiment, which is what you hear about with children, survivors of sexual trauma, who report that they leave their body and watch the incident from above or something like of that nature. That is the disembodiment. And there's a clear correlation between these dissociative reactions and severity of PTSD. So we know that by helping patients deal with the dissociation, we can help with the PTSD. So some of this I just touched on, but trauma is stored in the body, in somatic memory. And in PTSD, there's often a failure of declarative memory, and that intense emotional memories are processed outside of the meaning-making areas of the brain, which is the hippocampus, and more so living in the amygdala, which is the fight or flight area. So it's more difficult to extinguish if you can't make meaning of it. So there's a study in 2014, the capacity of successful encoding of autobiographical episodic memory is dependent on the experience of the world from the perspective of one's own body. So to leave one's body, then you will not have a successful encoding of the memory, leading to unresolved trauma. So Shore and Leotti have clearly related childhood abuse, neglect, disorganized attachment, and propensity for dissociation to the development and the severity of PTSD. So when children have a parent with unresolved trauma that relates to them with frightened or frightening states, these children are unable to develop an organized attachment to them, hence the approach withdraw. Eric Hess and Mary Main, 2006, called this fright without a solution. And this is kind of like the infant who just freezes in the strange situation, doesn't have a strategy. So infants with disorganized attachment exhibit some of the same behaviors as adults with dissociative symptoms. Some of these same exact behaviors are done with adults who dissociate. And that's actually where we're going to stop for today. And we're going to pick up next time talking about generally the second pillar, enhancing and fostering a wide range of metacognitive skills. We'll then talk about the third pillar, and then we will go back to the first pillar and talk about how to use it with each of the respective attachment styles. So I look forward to this course with you, and thank you very much for your time.